Hi, this is Patrick Horn, president of GAP. I'd like to thank Fujifilm for their support of this podcast.
Welcome to the GAPPcast, the official podcast of Gastroenterology and Hepatology Advanced Practice Providers. I'm your host today. My name is Mikhail Alper. I'm a physician assistant. For today's episode, thank you for joining us for another insightful episode where we dive deep into the world of GI and hepatology. Today's episode entitled Setting the Standard in Biomarker Validation. The EDRN example and lessons from liver cancer focuses on enhancing our ability to educate and discuss biomarkers with our members and our patients. Joining me today is Natalie Oliver. And Natalie, she's a physician assistant as well. Actually, now it's called physician associate, right? And she's a seasoned expert in the field. She's a hepatology expert in the field. And Natalie, can you tell us anything about yourself, where you're from, and little details?
Yeah, absolutely. So I practice in Houston. So I work for a private practice called Liver Specialists of Texas for the past 4 years. And then I also work with all of our liver transplant patients at Houston Methodist Hospital for the past 4 years as well. And I love it.
And just to share the information that we come from a little bit different background, right? I am in a private setting in GI hepatology, so I'm not just a hepatology. I do everything in GI hepatology in a private setting. It happened to be, it's in the middle of the California, Fresno, Madero. We have 2 offices. I have maybe several hundred, if not thousand, of the cirrhotic patients. And because nobody else wants to take care of them, and I try to provide the best care I possibly can to this underserved population, right?
Absolutely.
So our goal is to explain the need for standardization, the role of the networks like EDRN, and how to apply it to HCC biomarkers, right? And do you know anything about that? Can you share with us any information on that, please?
Yeah, absolutely. So, it's a great question, and it gets to the heart of making biomarkers, especially for HCC surveillance in this case, clinically significant and also reliable. So when we talk about biomarkers, number one is the importance of standardization. So standardization is essential in reproducibility across different clinical practices, state by state, California, Texas, different patient populations, because without this type of standardization, we can have the same biomarkers producing results that are inconsistent based on where they're drawn or when they're drawn. So in order to keep this consistency, we try to focus on 3 things. So number one would be common protocol. So again, between different labs, between different states, we want to make sure we're collecting samples, be it blood, tissue, collecting them the same, processing them the same, so that we can produce similar results. And we want to keep these procedures across lab by lab the same. We also we need validated assays and reference materials. So biomarker tests must use calibrated instruments and control samples with known concentrations to ensure that the results are accurate and comparable across different sites. And then lastly, we want to use harmonized study designs. So in the clinical validation and the testing phases, we want to be using the same inclusion criteria, statistical approaches. We want to measure outcomes the same. So again, the results are going to be meaningful and translatable across different sites. And this level of coordination is not easy. So we do rely on large national and international regulating bodies, as well as academic centers and consensus guidelines from professional organizations. And when we have these overseeing boards, then we as clinicians can be confident using the biomarkers that we're providing the best practice and care to our patients.
And is there an organization that happened to drive this?
Yeah, so several networks, one like you mentioned, NCI's Early Detection Research Network, also known as EDRN, and their role focuses on this type of collaboration. So by working to set best clinical practice, by providing resources, and then helping guide these markers through validation phases.
Can you name the markers that you're talking about?
Absolutely. So again, we bring it back to HCC surveillance. And as you said, this is something I think about every day. So you and I, I'm sure a lot of people listening, we have a very high risk population for HCC. So, be it with cirrhosis, chronic hepatitis B, chronic hepatitis C, we use standard of care, which is AFP and ultrasound. And while it's good, I wouldn't say it's perfect or great. So, I really get excited about organizations like EDRN because it challenges the status quo. So, they're able to look for new biomarkers, validate them, also to improve surveillance accuracy. So by investigating these new biomarkers, we can see increased specificity, sensitivity. We want to detect HCC early, but at the same time, now, I'm sure I'm not the only one to have a elevated AFP and we find no HCC. So we also want to prevent false positives because that leads to additional testing and screening, which can be uncomfortable, costly, and creates a lot of concern for our patients, honestly. So again, with these types of networks, they can facilitate these multi-center massive studies to validate biomarkers, which is exciting to have new things on the horizon just for better HCC surveillance.
And which one do you use in your practice besides the AFP and the ultrasound?
Yeah, so like I said, we could do better with HCC surveillance. So every time I order an AFP, I also order an AFP L3, which is a little bit more specific to the liver. We also, through EDRN, they validated another biomarker called PIVKA-II, which is also known as DCP, which is actually what I hear.
Tell me that because I never heard about PIVKA-III. I've heard the DCP, but not. Thank you.
Right. And so I also, in clinical practice, have heard it as DCP. And so now when I have an elevated AFP, if I have an L3 and a DCP, I can calculate something called a GALAD score, which then helps me risk stratify my patients, know the percentage, the likelihood of them truly having HCC, which helps guide which imaging modality I want to get, and also really the conversation with our patients, because liver cancer and that concern is, of course, can be a scary conversation, but when you go in with more confidence with these new biomarkers, it makes for, of course, better care and better conversations.
Absolutely. As a matter of fact, I utilize the same strategy. The only thing you got it more advanced than I am. I'm lazy. I don't do the GALAD score, to be honest with you. I just go to AFP, AFPL3 DCP, and the ultrasound. If I do see some elevation in the AFP, AFPL3 DCP, I don't see anything on the ultrasound. I do proceed with the triphasic CT scan or MRI with special dyes in order to contrast, in order to get a little bit more specific details on that. Do you utilize the same approach?
Exactly. So if ultrasound doesn't show anything and I still have these elevated AFPs, or be it an L3 DCP, we do typically first an MRI liver protocol, which is of course with and without contrast. And then sometimes I will use the CT triple phase. There are some patients who can't have an MRI, be it different devices, or sometimes claustrophobia really does limit these scans too. So we'll use a CT triple phase. But that, I would say, is one of the best looks at the liver. And I use that, of course, if I see these abnormal surveillance tests.
And I'm glad you brought up the information on who are the patients that you screen for the HCC, because I had a very sad story from my own practice when I had a 43-year-old gentleman who had hepatitis B, and I diagnosed, he came to me, to my practice, with hepatitis B at the age of 37. We did treat him successfully. He had undetectable viral load, right? At the age of 40, I offered him an ultrasound, like its guidelines, and alpha-fetoprotein, and he did it, right? But then he was a little bit on the chubby side, and he switched to the fibroscan. And I explained him that. I said, the fibroscan cannot pick up any tumors in the liver, right? So he refused for 3 years. And I remember that so well. It was such a sad story. He passed away at the age of 43 with undetectable liver cancer. By the time he was diagnosed, it was 8-centimeter liver lesion. So again, it's again and again, please, we need to remind our providers to look for that, okay, to make sure, because if we diagnose it early, the chances for survival is extremely high, correct?
Exactly. And, on kind of the flip side of that too, when we're talking about patients who don't have cirrhosis, who are still at an increased risk for HCC. So, of course, Hep B and Hep C, but then also MASLD, right? We're finding,
Absolutely.
which
Absolutely.
is, with the surplus of patients with this metabolic related fatty liver disease and then newer guidelines for HCC surveillance. But if we can find it before they have cirrhosis, the success with the hepatectomy, removing it, the liver being the best organ, biased, but growing back within, 6 weeks or so is pretty amazing. And it's curative. And then, on the other hand, and remind me, do you do liver transplant? Do you work with a liver transplant center
I
as
do
well?
work with, majority of my work is with the Stanford, UCSF, and California Pacific Medical Centers. I do have some patients with UCLA as well.
Okay. Okay. So, I work what feels like really every day with our surgeons and liver transplant team at Houston Methodist Hospital. And when we are able to detect HCC early, in the context of transplant, when you find HCC with cirrhosis, and this could be a whole nother podcast, but too quickly, you know, when we find this early, ultimately, the cure for HCC with cirrhosis is a liver transplant. And while we do want to treat the cancer to prevent growth, reduce the risk for metastatic disease, the risk for recurrence is so high that ultimately we try to transplant these patients. And if you find the HCC within Milan criteria, so if it's one lesion, between 2 and 5 centimeters, it changes a little bit if you have multiple lesions. But by identifying these patients and finding the lesions early, you're so right. This is survival and mortality, and these are real people. So when you have these real stories to back it up, it emphasizes the importance of routine HCC surveillance, talking to your patients about it, and again, good biomarkers.
Absolutely. Thank you so much. And as we wrap up today's episode, I want to thank Natalie Oliver for joining us and sharing such valuable insights. And I also would like to say that it's absolutely thank you to our listeners as well, right? And for tuning in. And we hope this episode helps you feel more equipped and confident in discussing biomarkers, whether it is with your colleagues or patients. Remember, you are not just providing care, you are educating, which is a vital part of our role. Again, thank you so much. Appreciate it. Looking forward to see you at GAP, right?
Yes, and it's so nice to meet you, and thank you for having me so much. It's always so fun to collaborate, so I appreciate it.
Thank you so much. Appreciate it.